Yeah, it's a pleasure to be here. Now, I'm down to talk about pain and also topaz. And it's a bit of an advert for this trial that I'm running. I'm actually going to talk about pain first. I gave this talk at a meeting, an OI meeting that Patricia organised in Dundee. And not that I'm a pain doctor, but it went down well. So anyway, I got asked to do it. So first of all, pain. And Kaz has touched on this. Pain is quite a complex symptom. Here's the kind of dictionary definition: unpleasant sensory and emotional experience associated with actual or potential tissue damage, or, and this is important, or it's described in terms of the damage. So there isn't always damage when you have pain. And this diagram here is the so-called psychosocial model of pain. If I can take you through it, pain is not just hurting yourself, hitting yourself in the thumb with a hammer. There's a whole lot of stuff that influences how you perceive pain. So there is the painful stimulus at the bottom, but then how you perceive it at your level will depend on your reaction, which depends on your background, your upbringing, and also it will depend on how you're feeling at that time. Like if your dog died the day before and you have a painful stimulus, it's going to be worse than, you've just won the lottery. So, and I think we can all understand that. This is very, very important. And then also how you feel about your condition, if you feel terrible about having the condition, or maybe if you've come to terms with it. And then also things like socioeconomic and cultural factors. So there's a whole lot of stuff going on that will influence your perception of pain. Now, I'll give an example, a couple of examples. These are the kind of psychosocial factors. Now, on the left-hand side, you have a picture of this festival which goes on in Thailand, the so-called Ma Song festival. And it's traditional for people that take part in this festival to, as in this chap, stick needles and knives through themselves. And these people apparently do not suffer pain. It's a bit like the Maharajas that would be sitting on, mats of nails and stuff like that. And it's like mind over matter, basically. And then pain, we always think of pain and a distressful thing. If you look at the right side of the slide, sometimes for some people, pain is not a distressing thing. On the contrary, Kaz touched in this, and it's just how pain works. So you have an injury, let's say a fracture. We're talking about osteogenesis imperfecta. That will cause bleeding into the tissues. It will cause swelling. It might cause deformity. So that will release chemicals, if you like. An important one is prostaglandins and cytokines. These are kind of chemicals which then will stimulate, on the bottom of the slide, your nerve terminals. We've all got nerve terminals almost everywhere, and those can be activated by things like being deformed or these chemicals. Then that will trigger the nerve impulse. There are certain types of receptors, like our nerves detect pain, but they also detect fine touch. But the receptors that detect pain are so-called nociceptors. Okay, that's what mediates pain. So then what happens is the signal travels. Say I bash my thumb. It travels into your spinal cord, actually goes over the other side of the spinal cord, and then travels up into your brain with the blue pathway. And then it's perceived by your brain. And you think, bloody hell, that was painful. Now, the other thing that can influence that is we have what's called descending pathways, and they're shown in red, and these can influence how the pain is perceived. They can block pain, for example, like in the Ma Song Festival. So this is all very complicated and very interesting. Now, so if we look at the different types of pain, Kaz already talked about neuropathic pain and rheumatoid arthritis. Anyway, so nociceptive pain, that's if you smash yourself, you cut yourself. There's what's called inflammatory pain. We see that in patients with arthritis, and that is due to chemicals that are released as a result of inflammation. We have what's called neuropathic pain. Most people will have heard of, like, people maybe having an amputation, but they still feel pain in the limb that's been amputated. So that can be caused by nerve damage. And then there's kind of non-inflammatory, non-neuropathic pain. Just an example of that is a condition called fibromyalgia, which is a condition as rheumatologists see. And in that condition, it seems as though there's something wrong with the perception of pain. So someone with fibromyalgia, if I touch myself like this, give myself a prod, that's no big deal. If you touch someone with fibromyalgia like that, they go, oh gosh, that really hurt. And we think in fibromyalgia, there's something upregulated in the way that patients just perceive the pain. And we don't know what it is, but that seems to be what is going on. So, many types of pain. Now, if we turn to osteogenesis imperfecta, there's quite a lot of types of pain related to the osteogenesis. For example, obviously, if you have a fracture, that will cause pain. If you've had lots of fractures and that causes your bones to become deformed or bent, that can cause pain. Spine, a lot of fractures in the spine, that can cause pain. And then the other thing that many people with OI have is laxity of the ligaments. So they can get ligament injuries, tendon injuries, hypermobile joints. And I'm sure all of you in the audience with OI will be familiar with that. But people with OI are not immune to other types of pain. They could get fibromyalgia, they could get neuropathic pain, they could get inflammatory arthritis, they could get osteoarthritis. So there's pain associated with the condition, but also pain that is due to something else. Now, just a couple of examples, acute and chronic pain. This is it's actually one of the patients in the Topaz study. He was doing some weights at the gym, and he just broke his wrist. He kind of too heavy a weight, actually. That was an acute pain. It all healed up, and he was fine. And then on the other side, the right-hand side of the slide, again, someone with OI, a lot of fractures in the spine, and this patient has quite a lot of chronic pain. The fractures have occurred, there's a bit of deformity there, and the pain is continuing. Okay. Now, what can we do about the pain? What are the medicines? What helps? What doesn't help? Well, in acute pain, painkillers or analgesics, as docs call them, they can be very effective, especially opioids. And I had surgery this summer, and it was bloody painful, I can tell you. And I got some opioids, and wow, they were fantastic, really. But I'll tell you, see, about 4 or 5 days, I didn't need them anymore. The first day, I was on about 6 a day. The second day, the nurses in the hospital thought I was a junkie. I was saying, I need the drug. But then, actually, by the third day, I only needed them twice a day. By the fourth day, once a day. By the fifth day, I didn't need them at all. So they are fantastic for acute pain, but for chronic pain, they are not fantastic because they don't really work in the long term, and you have all sorts of problems with addiction. And I'm sure many in the audience will have heard the opioid crisis. You maybe heard this. So great for acute pain, not for chronic pain. The other thing that it helps after a fracture is just having your bone immobilized. That's a fantastic pain reliever. And those of you who had fractures will no doubt have had plaster casts, or you've had kind of nails put into your bone to fix it. So in chronic pain, that's more difficult to deal with. There's a lot of different treatments. I've called them neuromodulators here. So these are drugs that influence the transmission of pain signals by nerves. Okay, that's how they work. Popular ones are what's called gabapentin and pregabalin, and they work by interfering with nerve transmitters called GABA receptors. There's things like amitriptyline, which used to be used as an antidepressant, but it also affects nerve terminals, affecting uptake of a chemical called serotonin and noradrenaline. Duloxetine is another one. Nowadays, or quite recently, ketamine is a very, very powerful painkiller which acts on a receptor called NMDA. That is starting to be used. It's only under very careful guidance because it can do a lot of harm under the wrong hands. I'll just touch on cannabinoids. These are in the news. Everyone's thinking, well, cannabinoids, that's a cure for everything. Cannabidiol. And then at the bottom, there's a very interesting group of drugs called nerve growth factor blockers. These are very powerful painkillers, actually. And they've been studied in osteoarthritis, and I think they may become available. But there were worries about they were too powerful. When they were in clinical trials, what happened in people with osteoarthritis, they were so effective that the patients that got them kind of forgot they had osteoarthritis. You know, patients that might be limping along, and then they were kind of doing marathons. And unfortunately, what happened was the joints of these patients just got wrecked because they weren't perceiving any pain at all. And but anyway, I think they may come back, and I think they could be a useful treatment. Now, cannabinoids, there's a massive amount of hype about cannabinoids. You would think that cannabinoids were a cure for everything. I don't think they are. I think there's a huge amount of hype. There have been research studies on cannabinoids and pain. I'm showing a photo of what's called a Cochrane review. This is a very highly respected kind of organization that will look at the evidence. And the conclusion was that, at least from the studies that had been done so far, cannabinoids, things like cannabidiol, THC, were not really very effective in chronic pain, contrary to what you might imagine. And then we have an interest in cannabinoids, not personally. I may have had a joint, never inhaled, okay, like Bill Clinton. But we did a study, it's shown in the bottom, in an area of Edinburgh. We called it colloquially the Muirhouse study. Now, Muirhouse is a rather socially deprived area of Edinburgh, and there's a lot of cannabis use there. And so we were interested in looking, if you're a very heavy cannabis user, did that affect your bones? We had some evidence from preclinical studies that might, and in fact, we found that if these heavy cannabis users, they did have low bone density and more commonly fractures. So there may be a downside of cannabinoids as well. So, and I think that's not something that's publicized. So cannabinoids, so I wouldn't be recommend. I have pain. I'm not going back to smoking joints. Now, I mentioned that how your mood can affect pain, and of course that is very, very important if you're depressed. And there's a vicious circle. If you have pain, you can get depressed, and because you're depressed, that makes your pain worse. So that's very important. Traumatic life events can lead to pain, and you've probably heard of post-traumatic stress disorder. So this is where often, like soldiers, like people in the Gulf War, or then more recently in Afghanistan, I've seen patients come to that with pain, and the experience they had in those theatres of conflict, caused them to have pain. It's very difficult for people to understand, but it happens. It's a true fact. If you've been abused physically or mentally, that can make pain worse. And your reaction to pain is very important. If you're on top of it, you can come to terms with it. That's great. There's a thing called catastrophization, where if your reaction is, oh God, no, that's bad. You've got to try and stop doing that. So that's pain. It's very complex, and managing it isn't very easy. But there are some things you can do. And very important is non-drug treatments, basically. So I'm sure you've all heard of mindfulness. So that's a bit like the mass song people, like, you're taking control of it, mind over matter. Peer support. Everyone in here is giving each other peer support. You can talk about your pain. That can help you. If you see someone else pain, oh God, my knees are really sore. Are they? Oh, my knees are really sore too. And that can help you. I speak from personal experience. Sometimes psychology can help. In fact, we've got a psychology speaker I noticed today. And if you do have pain, things like physio, occupational therapy can help, joint protection, help you to avoid things that are going to cause you pain. So that's important too. And then you've all heard of acupuncture. So that acupuncture works by stimulating the downward pathways that stop the pain going up. And so they act as a kind of gate, basically. And TENS is thought to do the same thing. So that's a bit of pain. And I emphasize that medication is only a small part of the package. So medicines can work, but it's not only medicines. Now, which brings me on to Topaz. And can we do better with OI? Now, as I've said, not all of the pain in OI is due to OI, but a critical thing is the fact that if people had a lot of fractures and their bones become bent as a result of it, that can cause pain. So if you could prevent some of those fractures, that could be beneficial. And the Topaz trial is designed to look at that. It stands for treatment of osteogenesis imperfecta with parathyroid hormone and zoledronic acid. And we've had great support from the BBS on this. It's funded by the NIHR, that's EME, and there's a little logo, and there's a very famous physician from the Bridge of the Starship Enterprise. Apologies to younger members of the audience, you probably won't recognise him. Now, the Topaz study is in adults with OI. It's not in kids with OI, you've got to be older than 18. What I'm showing here in this diagram is data from Denmark, and it's one of the, in fact, it's probably the best study which will tell you how commonly people with OI get fractures. It's very poor data until only 2 years ago. As Cass said, often we don't have good data. This is excellent data. It's from Denmark. And they have a very advanced electronic healthcare system. So everything is registered if you go into hospital and you have a fracture. And what you can see, men or males on the left, females on the right, see when you're a kid, that's the shaded area, you have loads of fractures. So OI, loads of fractures when you're a kid. But then even with no treatment at all, they go down, which is is good. So fractures go down as you get older. Not clear why that is. One thought is that maybe you kind of twig and you don't do crazy things and put yourself at, but probably another thing is your skeleton is growing, and just because you're growing, you're less likely to break a bone. But what you can see is if you look at the trajectory with increasing age, some of the very old age groups, there's not many OI patients there, but it's about, fractures in OI, even in adults, are about 50 to 100 times more common than if you don't have OI. So all throughout life, if you've got OI, you are a greater risk of fracture. I encourage anyone that might be thinking about it to consider it, and happy to take questions. Thank you.